Hello everyone. Today's video is about a couple of questions about POTS, which is postural orthostatic tachycardia syndrome, and also about a case of MCAS that resolved and how the heck that happened. Just before jumping into the video, if you don't mind taking a quick moment to please like, share, subscribe, and or post a quick comment on the video, I'd really appreciate it. So thanks in advance for taking a second to do that. And as per usual, nothing I'm saying should be construed as medical advice. This is for informational purposes only. If you need medical advice, please talk to your healthcare provider to get that advice. So I posted a video about POTS a little while ago, 3 months ago, and it was called Saltwater Protocol for Managing POTS. And there were a couple of questions on there. So one of them was, I noticed you say low blood pressure. I've read that you could also have high blood pressure if there's hyperadrenergic POTS. So in the video, I would have mentioned something about low blood pressure and basically how with POTS, the issue, if it's a hypovolemic or a vascular POTS, which to my understanding is the vast majority of POTS cases, there's basically a low blood volume, and that low blood volume, and sometimes it's related to like a poor vascular tone, but basically if there's a low blood volume, then or poor vascular tone, that will lead to low blood pressure, and then the body will respond by increasing the heart rate to increase the blood pressure, and so it's ultimately a low blood pressure issue, whether it's due to low blood volume or poor vascular tone that leads to a low blood pressure, and then there's the compensatory tachycardia, the increased heart rate. But when folks with POTS, oftentimes they have low blood pressure. So you'll ask them, when you get your blood pressure checked, do they usually tell you have low blood pressure? Like, yeah, it's usually low. It's not always low. There are cases where the blood pressure is fairly normal, or it might be like low, but not necessarily to the point where whoever's checking the blood pressure, does the eyebrow raise, like, oh wow, your blood pressure is quite low. They might be 100 over 60, or they might be 105 over 65 or something like that, and still have POTS potentially, because again, that increased heart rate is compensating, and sometimes we don't see that low blood pressure. Indeed, when we do something called the NASA lean test in office, i.e. one of the diagnostic tests for POTS, we'll oftentimes see that the blood pressure readings don't look that bad. We'll see, the patient's lying down, checking their heart rate on their blood pressure, they stand up, we see their blood pressure staying pretty consistent, but the heart rate is going up through the roof. So now if we continue the NASA lean test, it's a 10-minute long test. Ideally, 10 minutes of measuring heart rate and blood pressure when they're standing up. There's a lying down phase ahead of that, so it takes longer than 10 minutes in total. But it's always, I think it's quite fascinating to see how the blood pressure and the heart rate start to compensate over time, as well as the pulse pressure. And in some patients, we'll see that they sustain, that elevated heart rate and blood pressure for quite a while. And then in some patients, we'll see that their blood pressure does indeed start to drop down. We have patients where their blood pressure drops so low, we can't even detect it with the blood pressure monitor anymore. We have patients who have actually passed out or nearly passed out, as the test is progressing, because their vascular system, their autonomic nervous system just can't compensate for the standing anymore. And so those are pretty extreme cases. So it's certainly not to say that having a normal folks can have a normal blood pressure, or potentially even elevated blood pressure in the case of a hyperadrenergic POTS, but they could have normal blood pressure with vascular POTS as well. So thanks for the comment/question on that. The other comment, or the other question rather, on this video was, would it be similar if you, okay, sorry, I'll give the context first. So in this video, if memory serves, I talk about adding salt to water and kind of distributing that salt in the water throughout the day, basically using the sodium and the salt as a lure to draw more water into the vascular system to help address the hypovolemic issue, like the blood volume issue with vascular POTS. So the person was asking here, would it be similar if you if you ate a lot of salty meat and drank lots of water? So thank you for the question. What I found is that for folks, unless they have very, very mild POTS, they usually need to be pretty meticulous with making sure that they're getting enough sodium in their system through in their water through the day. So I suppose if one was going to be very careful with their salty meat, and they figured out how they could eat, enough meat spaced out through the day, and they were drinking water along with that. That could work, because it really just needs to be the water plus the appropriate amount of sodium kind of distributed throughout the day. That's the recipe for the salt protocol for POTS. However, most people would not do that, and it'd be a lot easier just to add the salt to the water. So I suppose it is theoretically possible. And if it was like, oh, I'm going to have some salty meat, maybe that would preclude the need to have salt water, say, at that meal or around that meal time. But I think it would get a little bit tricky to know like exactly how much salt is in that meat, because for example, if I'm roasting a chicken or something like that, I put a bunch of salt in there, but how much of it's getting like lost in the drippings in the pan and this and that. So like to know exactly how much salt/sodium is going to be in that meat, I think is going to be pretty tricky to know for sure. So I don't think it's really something that would practically be able to be used as an alternative, but if one really, really wanted to, I'm sure they could figure out a way to do it. And then just switching gears here to the MCAS. So I posted a video 4 months ago. It was called Case Example Successful MCAS in parentheses histamine treatment. So I did like this little mini case series where I talked about a few different conditions, like I think a chronic Lyme case, maybe a SIBO case, an MCAS case, a mold case, maybe another one I can't remember now. And it was just a example of a successful outcome with that condition. Someone had asked me to post videos about saying like, can you post some successful cases, so that gives us hope for those of us who are still in the trenches dealing with these conditions. So I thought that was a great idea, so I did that. So the comment, so that's the context for the question. And so then the comment was, or slash question was, how does that happen? How did he, this male patient in the case, how did he manage to go off medication? What happens? He instantly had no more MCAS. Can you explain what exactly happens in the body? Because I've been getting worse and worse, less foods, less tolerances, and then just goes on a little bit more with their personal details there. So thank you for the question. So as I said in the video, the patient was able to wean off the antihistamine medications, didn't need them anymore, and that was really wonderful. So in this case, if memory serves, as I believe I described in the video, with histamine, it's like a self-fulfilling prophecy. The more histamine that's there, the more histamine gets released, because we have histamine receptors on our mast cells. And so the more histamine that's there, the more histamine gets released, so even more histamine gets released, so even more histamine gets released, and it's this positive feedback cycle. So in this case, we basically were able to identify the underlying triggers that were leading to the patient having histamine-related issues, and then we also worked with the appropriate medications and supplements to help quench the histamine enough. So it's kind of like there's this big, like, I kind of think of it as this histamine mushroom cloud, and it's just this self-perpetuating problem. And so when we work with the mast cell stabilizers, antihistamines, and things like that, it helps to kind of like reduce the size of that mushroom cloud, so it becomes less and less of a problem. And once things get squashed all the way down to not having any more histamine, or not having excessive amounts of histamine floating around, because we all have histamine in our bodies every day. It's a crucial part of our physiology. To my understanding, we would die without histamine, so it's not like it's this evil thing that's not supposed to be there. We just should have appropriate amounts and definitely not have a mast cell activation syndrome happening. But once we get the histamine wrangled in, then it just stops perpetuating the problem, and just things go back to normal. The body keeps the histamine in check, and it's, the wild horse is left the barn, now it's back in the barn, everything's good. So that's basically what happened in this particular case. Now, it's important to note, and this question sort of alludes to this, a lot of cases with MCAS are really, really complicated. This was not a super, super complex case. With a lot of cases, it isn't until we get into the mold treatment, or remediation of mold exposure, or we get into the SIBO treatment or other gut treatments, or we get into the Bartonella or other systemic infection treatments, whatever is driving the MCAS, to say nothing of the role that the amygdala plays, or the autonomic nervous system dysfunction regulation can play in perpetuating histamine issues, because stress hormones lead to more histamine release as well. So a lot of cases are really complicated. So I'm certainly not insinuating that every MCAS case is as kind of cut and dry as the case that I presented. So because they're certainly not. So if that was kind of part of the subtext of the question, yeah, a lot of cases are a lot more complicated, but that's what happened in this particular case. So I hope this information was useful. If anybody has any questions on these topics or anything else, just post in the comment section below, and I will do my best to answer as soon as I can.